FM. Our guest this morning, been with us many times over the years. He is a retired ENT from Somerset, Kentucky, Dr. Kevin Kavanagh. In 2008, you, Kevin, began an organization called Health Watch USA. So you were still practicing at the time. You retired in 2010, and Health Watch USA is alive and well, and I can't pick up the newspaper without seeing your articles in it.
Yeah, it's been really a busy 2 weeks. We've had inquiries from news medias from California to South Carolina. Of course, we've been in paper in Kentucky a couple of times, but...
Gosh, you've been in the Herald Leader a couple times in the last couple of weeks, it looks like to me.
With op-eds.
Yeah, with op-eds. Yeah. It's all because of this program. You know, we made you the man that you are today.
I have to really admit, a lot of it did come from this radio station and getting the word out through it.
I'm kidding you. This morning, we're going to talk about a bunch of different things. I know you've done research on a lot of things, and with all the writing that you're doing and op-eds that you're doing specifically, what seems to be the topic that people want to hear about most?
Well, right now it's infections and the new CDC release of their new data that relates to staph infections. This is just staph in general, that we currently have 119,000 Staph Aureus infections each year with almost 20,000 deaths. And a large percentage of those are MRSA or MRSA, which is the drug-resistant form of staph. And so this is a big problem.
Is that something that is acquired usually in healthcare facilities?
Well, one of the problems we have is arguing over where it's acquired instead of just taking care of the problem.
Yeah,
because everybody points their finger to someone else.
Okay.
My experience is hospitals will sometimes point it to nursing homes to hospitals. People point it to the farm, which I think is not the driver of our problem. So it gets really hard. But what is apparent is that in 2015, the Department of Health and Human Services set a goal to decrease MRSA by a half. And according to the CDC, the rates have decreased since then, have stalled. We've hardly budged the needle. And that's one of the findings that I'm very proud of, that Health Watch USA was able to figure out. In 2017, we alerted the CDC that MRSA rates weren't dropping. In fact, we had some indications that they were going up. We went down to Atlanta, talked to them, and lo and behold, we were right. As years progressed, in 2018, more data came in, and rates are not dropping, and this is something to be concerned about.
And so this MRSA that you're talking about, is there no antibody it's not resistant to? Or?
Well, there are antibiotics that it can be treated with, but these become more stronger, and of course you then get into the cycle of it can become then resistant to that antibiotic. So you want to take care of these severe infections. Even the staph, which is not MRSA, is a serious infection. People would die of staph infections commonly before the rise of MRSA. And so we need to address this. And one of the things that really bothers me is, for example, if you're going for surgery, World Health Organization recommendations are that for all major surgeries and for all surgeries in general, if your country has the capabilities, should be screened for Staph aureus, for just general staph infections. And if you have that, decolonized. Well, in the United States, we're not even doing this for MRSA on a routine basis. And so I think that is a huge problem. We have kind of relegated MRSA to, well, everybody's got it, so we don't need to do anything about it. There's some hospitals and some facilities that are not even isolating patients with this type of infection. And that's definitely not in line with CDC thinking that does recommend isolation of all known carriers of MRSA and of all people that are infected with MRSA.
When you first started coming on this program, and you've been on this bandwagon for a long time, you started talking about MRSA and staph, and also something called C. diff, which I had never heard of. Well, lo and behold, my mother went into the hospital for some minor surgery. I forgot even what it was for, but then got C. diff while she was in the hospital. And it was, it's a horrible, horrible thing. Is it worse than MRSA, or is there a way of ranking them?
Well, it's hard to say what's worse. I mean, if you've got a bacteria that has a good chance of killing you, it's hard to say that one's worse than another.
Yeah.
But certainly C. difficile is a terrible infection. I mean, you can lose parts of your intestine or your whole intestine, your large intestine from it. And of course, with MRSA, you can lose a limb or a leg. So even the survivors can be disabled. And C. difficile, the activation of that infection is related to antibiotic overusage. We still have a huge problem of overusage of antibiotics and the using of the wrong antibiotic. People are still getting Cipro and fluoxacillin for common upper respiratory tract infections.
And that's incorrect?
That is incorrect. In fact, there's been a number of FDA warnings regarding complications from this antibiotic, and it should not be used for those types of infections. It's, in my opinion, a very high-risk drug, and there are other drugs that have better efficacy for those types of infections.
Why are doctors, they're the ones writing the scripts?
They are the ones writing the scripts.
Why are they doing that?
That's a question that you should be asking the medical profession. The same is true with our opioid epidemic. It started, a lot of it, from prescription opioids and pain medications. Yes, they were marketed and given information that it can be used in chronic pain. However, common sense and training, and I mean, I was during that time, I didn't take much education to figure out that was a wrong way to go, would indicate that probably shouldn't be prescribed to this category of patients.
I know that patients come in with an expectation of an antibiotic, whether they need one or not, and a lot of doctors will just write them if they insist on it, even though it's not what they need. Did you encounter that in your practice?
I did, and sometimes patients would get upset.
Yeah, because you
have to talk to the patient about not getting an antibiotic, which takes time. Also, if you code your billing, you have 5 different levels of visits. If you prescribe an antibiotic, you can oftentimes get a higher code, which can sometimes double your reimbursement. So you're talking about half the reimbursement for twice the time if you don't give that script. And so there are some problems there. However, in nursing homes, the patients aren't demanding antibiotics, and you still have a huge problem where in some research articles that they found over 50% of antibiotics given are inappropriate. So you still have the problem in nursing homes. So it's not fair to just blame the patient. The doctors in healthcare have to accept a lot of the responsibility. And what's disturbing to me is that over this last decade, 2 great public health care disasters have developed. One is the antibiotic-resistant epidemic, and the other is the opioid epidemic. And both can be traced back to being started by the healthcare industry. And so it's not a very good testament to how we're doing in the United States. We need to really stop doing this and change our ways, because it will be very expensive to get these 2 epidemics stopped.
Dr. Kavanagh, that it says that Kentucky is ranked 40th out of 50 states in the control of MRSA bloodstream infections. Why is that?
Well, I think it's because we do not have uniform standards of control. And this is one of the items I would like the CDC to do, is become more specific. They, I think, are slowly hedging towards that. But currently they are recommending isolation, but they're recommending just additional steps if you do not bring things under control. However, they are using the VA, or Veterans Administration system, as an illustration of how you can really drive the infection rate of MRSA to almost zero, I mean, very low levels. And the VA has used a system of screening all patients which are admitted to the hospital. And if they have MRSA, they are isolated. And this has been very effective. This is what's used in the United Kingdom. They've also driven down rates, and there have been a number of research articles, good articles, that are well controlled, that have used this type of a system. And one of the things that's also apparent in both the VA data and the data which is released by the CDC, national data, is that it is the targeted modalities that are targeted towards MRSA that are driving down the infections, such as isolation. Because if you look at the run-of-the-mill staph, sensitive staph that is sensitive to antibiotics, those rates didn't decrease. So hand hygiene would be expected to decrease both. And hand hygiene alone, I feel, a backup measure, because these dangerous pathogens should not be on your hands in the first place. these antibiotic-resistant organisms. So it is extremely important, I feel, for institutions to take interventions which are specifically targeted to these organisms. And it will be expensive. It will be expensive.
Yep.
But if they don't do it, they will soon be in a position where they may be losing service lines, such as transplantation, chemotherapy. All of these, where you have immunocompromised patients, will be at risk for infections or poorer outcomes from these organisms.
This is Ken. Hey, Ken.
Good morning, sir.
Good morning.
How are you all doing today?
Doing well, thank you.
I wanted to talk about two situations. First one was my father when he was in a nursing home, and it seems like that one, either a hospital or a nursing home, you develop a lot of stuff in your lungs.
Yeah.
Anyway, it could be pneumonia or something, or further goes into, I guess, staph infection, what have you. I don't understand all that, but anyway, we have put a feeding tube in for him, and then let him. It seemed like he developed that after we got him in the nursing home. Is that something that when you get into a situation like that with nursing homes that sometimes this develops or not? Really, he's got a good strong heart, but and that's what kept him going for years. He was almost 97. He had a good life, but that's my question.
Well,
does it develop in nursing homes more in hospitals? It seems like
it's hard to tell. I mean, they'll both point a finger at each other. At least that's been kind of my experience. But you have to realize, just common sense, a nursing home is going to be a high-risk area. You've got residents who have a lot of health problems. They're going to have infections and be given antibiotics. And they're, when you get older, as Shakespeare said, it's like your second childhood. They're very difficult to get to wash their hands and to have proper hygiene. And so it's almost like an organism will rapidly spread in that type of a setting. And I think that the nursing home industry is one of the industries which is at risk because of these types of organisms and infections. And that's why we really do need to start investing significant resources to get this cleared up. I mean, I feel the era of the seven-figure CEO healthcare executive salary may be coming to an end.
Do you really? Okay.
Yeah, I mean, I don't see how you can afford to run this top-heavy system that is so expensive and not invest the resources that's going to be taken and needed to clean up this epidemic. 10 years ago, it would have been a lot easier. And at that time, we'd hear we don't need additional regulations and guidelines. We know how to take care of it. And now the institutions that are in trouble, the running narrative is, well, these aren't that bad. We can live with this. Well, that's not what Europe does. That's not what the CDC recommends. We need to get this cleared up. If you don't get it cleared up, then you need to take additional steps like the VA, and that's what the CDC says. They highlight the VA as additional steps. And let's quit using the opioid epidemic as an excuse. There has been an increase in staph infections in drug users, and maybe that counts for a 5% increase in the MRSA, but that's not enough to be driving our problem.
Ken, anything else, sir?
Yeah, I just buried my sister yesterday from a nursing home as well, and she, when I went to see her Thursday, they said, we're quarantined, you can't come in and see her. And I said, well, how's she doing? Well, she's doing okay. Well, Friday morning, the family was called to come in, so, it was another situation of the flu and those type of things that was in the nursing home, so it was quarantined. But
well, and I think that's good. That at least shows that the nursing home is on top of, an effort to control these. It's become so prevalent. I mean, 2% of the people in the United States carry MRSA, maybe higher in Kentucky.
Ken, I'm sorry for your sister. I know that's tough.
Yeah.
And
well, she lived a long life too. So anyway, I appreciate you taking my call. I just wanted to share that kind of thing. And
thanks,
knowing that in hospitals it seems like that, and that if I know one time everybody said, I don't want to take them to the hospital because that's where they get it. So
it's very impactful and sad stories, and so we really need to look at putting in resources into getting these infections under control.
Gail, good morning.
Good morning.
You're on the air. Go ahead.
Yes, Dr. Kavanagh, I'm a nurse practitioner, and work in an ICU setting. I actually work throughout the hospital. And we have these people come in with multi-drug resistant organisms, and a lot of them actually develop multi-drug resistant organisms while they're there, I have to admit. But it upsets me very much that you go into a contact isolation room, and family is sitting there in their street clothes, and we've been exposed to him at home. And they're just taking it back out into the community, and they just ignore your precautions. They may be up in arms about it. Oh, where did you get this stuff? Well, it's because people like you have been at home. Do you see what I'm saying?
People like who?
Like who?
Like the visitors that come into the hospital.
I see.
And you have the patient on contact isolation, but the visitors don't observe that because they think, well, I've been in contact with this patient all along, and they don't take the necessary precautions, and they're taking these organisms back out into the community. And then they get up in arms. Where did it come from? Well, it comes from people like you that don't want to take the precautions.
Yeah.
Just like the flu, people that don't want to wear the masks and that kind of thing.
That's an enforcement problem.
That's an enforcement problem. I mean, we
Right.
have facilities that aren't doing contact precautions, and we have facilities that are doing them poorly. We have facilities that are so riddled with MRSA and some of these organisms that even if you did contact precautions, you've got to do proper environmental cleaning also.
Yeah.
So what you brought up also brings up the topic of hospital staff.
Hey, Gail, are you still there?
Yes.
Yeah. Can you hang on a couple, 3 minutes, because I got to take a break here? Dr. Kevin Kavanagh is my guest, and we have folks holding, but before the break, we have had Gail on the line. Gail is a nurse practitioner, and we've been talking about these infections that people get, either bring in or get in healthcare facilities. And you were saying a lot of the blame, in your opinion, Gail, is on the folks who are asked to put on some protection before going to see a loved one, masks and gloves and so on, and who don't do it. They don't comply. And I wanted to continue this discussion with Dr. Kevin Kavanagh. Dr. Kavanagh, that sounds like that's a facility enforcement problem.
It's also
sometimes you can only do so much because what can you do if they are there and they're refusing to comply? My point is everybody has to take responsibility. We are not at the top of the food chain. There are some pretty impressive resistant bugs out there. And people just have no idea. They have no idea. And I just think everybody needs to take their responsibility. I think that the nursing homes have to do it because their population are more susceptible. I think the hospital staff have to do it, and follow the guidelines that are set forth. And I think the visitors have to take responsibility as well because they're the ones that are going out into the community unprotected. So that's my point.
Thank you, Gail. I appreciate the call very much.
And I think that this represents really what I've experienced has been a decade-long of healthcare system mitigating the importance of this. I've heard this when I've testified before the Kentucky legislature, is that, we've got it under control. Staph infections, I remember one legislature said, well, it's only a staph infection. It's not always a big deal. Well, it is. This is something that's extremely important. And if you are a member of the general public and you are harboring MRSA, there's just been an article published in New England Journal of Medicine that shows that you can be successfully decolonized. And this will decrease your chances of getting an infection. In addition, healthcare workers are at an increased risk. They need to be screened for these organisms. You don't want to take them home to your families. We had a comment that I think was very good that Health Watch submitted to the CDC, and the CDC even quoted us in one of their industrial news magazines that were interviewing the CDC, that this is an important topic and that this needs to be addressed. And the healthcare workers need to have a safety net, an economic safety net, and protocols set up. Get them decolonized. 88% of healthcare workers can be successfully decolonized of MRSA.
Laura, good morning.
Good morning, Jack. Good morning, Doctor. Listen, I did nursing school back in the early 90s. I never finished. I'm not a nurse. But in the beginning of Intro to Microbiology, so this wasn't brain surgery. This is nursing students. We did a test called a culture and sensitivity. I wonder what that costs to have done now. I remember when I was a child in the 50s and 60s, if I went to the doctor with a sore throat, I got a swab down my throat every time. And his nurse grew out the cultures back in the kitchen. So it's not difficult. But if that was required, at least before some of the stronger antibiotics are prescribed, it seems like that would help. I had a bunch of kids, and I had one sore throat that just about bankrupted us, because every time I took a kid to the doctor, he just tried something else. It was a revolving door. And meanwhile, the whole family had caught it. But if they do that to start with, a culture and sensitivity, they know what they're working with and exactly which drug will kill it. Before you repeat all these drugs and you have whatever it is, you have it resistant to all those drugs they've tried. If you follow me. I know with the insurance billing system, every time the doctor runs somebody through the revolving door, it's another office call, cha-ching. So I don't know how to, deal with that at this point.
All right, Laura, I'm going to let you hang up and listen to his answer. What do you say?
Yeah, well, the majority of upper respiratory tract infections are caused by viruses, and they will not be impacted by antibiotics. I think that if you have a sore throat, it would be good to get a strep screen. If you've only had it a few days, you need to strongly consider maybe it would be better for me to just wait and see if this gets better over the next few days before taking an antibiotic. And that's if, of course, you've had a negative strep screen. Because one of the things you need to keep in the back of your mind is that antibiotics can cause infections, and specifically C. difficile. I've had patients that would take an antibiotic for a sore throat, and it was appropriately given, but they developed C. diff. And this is not a good thing.
No.
So you don't want to overuse these. You want to use them when it's appropriate.
Howard.
Yes, thanks for taking my call.
Sure.
This is a little off topic, but I wanted to ask, in the nursing home where I work, there are multi-pharmacies, and they prescribe like 15, 20 prescriptions, and I was thinking when I was in nursing school that over 5, and there are negative interactions, and I wondered if why they're doing that. If they know that there are all these interactions, why are they still over-prescribing? Why are they prescribing 15 and 20 pills for these poor little old people? And I'll hang up and listen to your call.
All right, thank you.
Well, polypharmacy is a problem. You have to be careful as far as antipsychotics in nursing homes. I feel that those are overprescribed. There have been several articles on that to make sure they're prescribed appropriately. And if they are overprescribed, the resident's going to be more apt to fall. They're going to be more apt to have additional problems. They'll be easier to take care of, provided they don't fall, but it's not good for the resident.
Right.
Antibiotics, as I've already mentioned, tend to be overprescribed in all healthcare settings, nursing homes included. And one of the things that the CDC has recommended is to consider 48 hours after a drug has been given at a nursing home is to have its appropriateness checked by someone else. In other words, a double check on that prescription. And so those are some protocols nursing homes can implement.
That's good. That's really good. Let's go to Ed. Good morning, Ed. Thanks for holding.
Good morning. I'm not sure my comment is relevant, but I had major surgery in one of the major hospitals here in Lexington. Ended up in ICU for a couple days. I was amazed that the hospital allowed all kinds of people to come in and out, little children running up and down the halls, 8 and 10 people in a room. Not in my room, but in the rooms up and down the hall. They had to be bringing in all kinds of germs and disease. And when I complained to the hospital, they said they really couldn't do anything about it. They could not enforce the rules to handle multiple visitors, and it was like some of the families just moved everybody in the family into the hospital when Grandpa got sick. So I'll hang up and listen to your answer if that's a factor in the escalating infection problem.
Good. I'm sorry it happened to you, but thanks for sharing that with us, Ed.
Yeah, I think that's a huge problem. Hospitals need to be able to have a clean environment, and they need to control the traffic within their facility. They need to have restrictions on the number of visitors and also age restrictions. I mean, kids, again, they're like the nursing home residents. They don't have proper hygiene. It's dangerous for a child to go into a hospital and be all of a sudden putting his hands everywhere, sticking it in their mouths, et cetera, et cetera. It's probably more dangerous to put a child into a facility unnecessarily than it is for an adult. So if you're bringing a child into a hospital or into a facility, you need to keep track of them and be very careful that that child follows proper hygiene. You want to make sure you use the alcohol rubs before and after, and that they're not putting their hands, rubbing them up and down on places, and again, putting their fingers in their mouth. You've got to have proper hygiene in these places. It's not only important for the patients, but it's also important for the visitors. So we need to overall have a rethinking of how we interact socially. If you go to India, for example, they don't like to shake hands. They'll do a fist bump at most. Yeah. And again, that's one of the reasons is because of spread of infection.
And that's not a bad idea for everybody, is it?
It's not a bad idea. And so there's a whole lot of different thinking that our population needs to do to get control of these epidemics and prevent spread of these organisms.
It's very important. Okay, this is one that says, I had C. diff in 1993. I was in isolation in one of the hospitals for over a week. I was only 53. I've been taking an antibiotic for a sinus infection. I really felt like I was dying. The pain was very, very bad. I was on IV pain meds every 4 hours. That's all he says, or she says. Here's another says, is there a rating or ranking for our local hospitals to see which is better or worse?
Well, there is, and in fact, that was a subject of an op-ed that we have in the Herald Leader. If you go to Kentucky.com and look at some of the recent op-eds or Google my name or MRSA, it should pop up, where we did rank the facilities. And overall, the facilities, I think a lot of them are underperforming. I tend to put the number of cases up there because you can say, well, we've got a bigger hospital, we should down adjust it, etc. But the cases are the numbers of people that are being affected, and the more people you have that are not doing well, the more resources you need to put into the problem. The CDC, unfortunately, and we've talked with them, risk adjusts a lot of these infection rates through this magical statistical thing called the SIR, which is hard to understand, and some of these rates are down adjusted by half, and they'll down adjust it for community rates, but yet they're not screening people coming into their hospital from the community. So instead of mathematically down adjusting these infection rates, maybe we should be putting in optimal protocols to prevent these infections.
And George has been holding. George, good morning.
Good morning. It's a pleasure to speak with you.
This is my friend George, the cab driver.
Talk to the doctor about sepsis.
Yeah.
That was what I was a victim of, and it put me in a coma for 4 months. That was a hospital-borne infection. I'm not going to mention the hospital, but I was put in their trauma unit. I was left covered in blood and with my eyes taped open, and there was dirty laundry beside my gurney, and it caused me to go septic. And the VA saved my life.
All right, what do you say?
Well, I can tell you, I personally think the VA does a very good job on patient safety. I know we hear a lot of dirty laundry, but they put all the dirty laundry out there, and they tend to address it. So the VA performs very well. Hospital cleanliness, environmental cleaning is extremely important. I mean, you can screen everybody that comes in through the door, but unless you do something about it, have proper environmental cleaning, proper contact precautions, enforce contact precautions, etc., that in itself isn't going to work. That's your starting point. to identify patients to do interventions. The laying on a gurney is extremely important. We see that all the time of patients being admitted to the ER. They're then relegated to a gurney. This is a factor in pressure ulcers. It's a factor, as you said, to acquire infections, because I don't believe you get the same nursing care laying on a gurney in a hallway. And unfortunately, with these tracking systems we have and the reporting systems, it's not till a couple days after admission, and admission doesn't count until you're admitted. It's not necessarily while you're laying on a gurney waiting to be seen by the ER doctor or waiting for that process to occur. So all of these rates tend to be statistically massaged instead of just looking at the numbers of patients that are succumbing to the disease and getting severe disability.
George, I'm glad you're better, and we're glad to have you back with us. He's a regular caller on this program.
Yes.
And he was one sick dude. Let's go to Sherry. Go on, Sherry.
Hey, guys, I just wanted to ask you exactly what is C. diff?
What is C. diff, Doc?
C. difficile is a bacteria that is a spore-forming bacteria that lives in your gut, and it's very difficult to treat because when you start to give it antibiotics, it hides into this little spore, which is like a fortress, and nothing can penetrate it. And it can lay then dormant for weeks or months and all of a sudden appear again. So if you get C. diff, it can be tough to get rid of.
Do you have it for the rest of your life? It just may not be active?
You can.
Yeah.
You can. And some people carry non-pathological or, more benign forms. But if you have one that's forming toxins and it's very aggressive, then you're in some trouble. There is a good treatment that I feel can be done called fecal transplantation. That's repopulating your bacteria in your gut. However, it's not FDA approved. The drug companies are fighting that. But in general, the antibiotics are not that effective. It will take care of some of the patients, a good chunk, but it will not be a universal cure.
Does that help?
Yes, thank you guys so much. Y'all have a wonderful day.
And the other side is alcohol does not penetrate the spores, so you have to use soap and water if you're around a C. difficile
alcohol
patient.
doesn't work. Okay.
Alcohol is not reliable on it.
JB, good morning.
Morning, Jack, and morning, Doc. Question is, do you know what the rate is of children dying as a result of acquiring infection and diseases from being allowed to run in the hospitals like they do?
No, we don't. In fact, right now, we don't even have a good tracking system to give you the exact rates of patients. The tracking system in the United States is very spotty. There's an EIP program, which is from 9 metropolitan areas and regions that tracks infections, and we have a national reporting system for bloodstream infections, but not all MRSA infections. Of course, a lot of infections aren't in your bloodstream. There's a picture of a necrotic hand. The hand's practically fallen off, but yet that wouldn't necessarily be reported unless there was a positive blood culture. So we don't have a good tracking system, and that's one of the things that we need to get. But it makes sense. I mean, I wouldn't let my kids run down the interstate without proper supervision. Hospitals are sick people that have dangerous bacteria. You need to be careful. And as was stated by the one caller, the contact precautions aren't always enforced if they're in place. And so to take a child into a hospital, you've got to really sit down with that child, talk to him about proper behavior, what's going on, and watch that child extremely carefully. It's not something to, bring the whole family in after Sunday church to visit mom or dad who is sick in the hospital. It's a good thought. It may make you feel better, but it's putting everybody at risk. You want to be very cautious. There are some hospitals that limit visitation to visitors over the age of 13, and so I think that is
probably good policy.
Good policy.
Yeah. JB, thanks. I appreciate it.
Thanks so much.
Got a couple of texts here. Iatrogenic or iatrogenic disease, third leading cause of death in the United States. My question is, how much do these infections contribute to this number? What they put is Latrogenic. Is that could, sometimes when people do these texts, they go fast.
Well, I think it's iatrogenic, and that means caused by the healthcare system.
Oh, okay.
And there's been a number of articles out that have advocated that healthcare errors are a major cause of death in the United States.
Okay.
there's a lot of debate around that. And whatever the number is you want to select, it is way too high. And I think that is something that we all need to come to grips with. Because with these organisms, you can say it wasn't my fault or the health facility's fault that I got MRSA in the community. Well, MRSA came from someplace, and it probably came from overutilization of antibiotics by the industry, and so there is some fault there.